I'm Dr. Jeff Yu, a board-certified ER doctor in the USA and Canada, and today I'm going to be reviewing the Pitt Season 2, Episode 4. Let's get to it.
Jean Samba, 54, half an hour of left-sided chest pain, history of hypertension on lisinopril and Crestor. Some relief with 2 nitro, decent vitals, no STEMI on 12 lead, gave him 324 chewable aspirin.
So there are some concerning features. So he has risk factors for a heart attack, given that he has high blood pressure. He looks to be kind of middle-aged. And they gave him nitroglycerin spray, which is a medication that helps to dilate all of your veins around and kind of alleviate some of the heart strain. So if you have chest pain that gets relieved with nitroglycerin spray, that is often a bit of a red flag that points more towards ischemic heart disease or heart attack kind of heart pain. So we would definitely take this patient in to be seen right away, start doing a lot of investigations like blood work, ECG, chest x-ray.
What's the plan?
Repeat 12 lead, check a troponin, admit for new onset angina.
Hell, you wait for...
Orders are in. Whitaker, try another nitro and let me know when the troponin's back.
Yeah. Hey, Jesse? Do you think you could repeat this, but with the chest leads on his back?
So sometimes the ECG will look normal from the standard views, but if you're concerned about a posterior STEMI, which is like the backside of your heart, then you would put the leads on the backside. And the main thing that would tip you off that there's a posterior STEMI is if there was subtle ST elevations in the inferior leads, like the bottom of the heart, or if there's kind of like ST depressions in other leads.
Why?
T waves are kind of high with ST depression anterior.
We see ST
There you
depression
go.
all the time.
Yeah, but could be a posterior MI.
All right, run it by the attending.
He's right.
If they agree, we'll do it.
Hey, Dr. Robbie gave the go-ahead for the back leads.
Sorry, man. I got to call a report on a septic patient going to the ICU.
That's a little bit unrealistic. Like if there is concern of a posterior STEMI, an ECG technologist would not rush off to go see a patient with an infection for an ECG. Like patients with chest pain are the highest priority patients for getting ECGs done.
Crap. What's wrong?
So this guy is dripping in sweat, and that's why the stickers are not sticking. This is very realistic, and that would be a major red flag in my own mind. It's not typical that a first-year resident would be doing this ECG on his own.
I'm having some trouble here with adherence.
Oh, of course you are. Try this.
Yeah, that makes sense. You think you could...
That's so interesting that they have that. This is actually so realistic. We have a lot of tricks in the ER in the hospital where we get things to stick better by using, I forget what it is. It smells like pine sol, but it kind of like you crack it open, spread it on the skin, and then it just makes the skin a little bit more tacky so that you can stick things on the skin. If you know what this is called, let me know, because I know exactly what this is in the hospital. I'd be able to see it, identify it right there in a cart, but I just don't know what it's called.
Do you mind if I paint some sticky stuff on you?
Sticky stuff, yeah.
You must prolong.
That's what I call it too.
You'll get to lie down afterwards. Holy shit. ST elevation V7, V8, V9. It's a...
So he's got a posterior STEMI. Most oftentimes this points towards a right coronary artery infarct. So that is, immediate criteria for cath lab activation, and they should be like drilling him with heparin, which is a blood thinner. Yeah, this is bad.
Posterior STEMI.
What's that?
It's the worst kind of heart attack. It's here. Pulseless VTAC. Start compressions.
So pulseless VTAC, they already have pads on. Oftentimes what we would do is shock them first and then start compressions directly afterwards. But very oftentimes when we're trying to scramble to get pads on and get a team in the room, oftentimes we will start compressions because it's just hard for us to actually get to the machine, start charging it and shock.
Charging to 200.
There he goes, yeah.
Okay, clear. Okay, resume compressions. Code STEMI, it was posterior.
Yeah.
Normal sinus.
All right. Got a strong pulse, check your BP?
All right, we'll prep him for cath lab.
So now they have achieved what we call return of spontaneous circulation. We would do post cardiac arrest care at this time. Like that would include targeted temperature management, making sure his body temperature stays in a normal range. We would activate the cath lab. I think that he already received 325 milligrams of aspirin by the paramedics, but I would call the cardiologist and ask if they want us to give a second antiplatelet agent like clopidogrel or ticagrelor.
Didn't show on the 12 lead.
No, usually doesn't. I think most clinicians would have missed it.
Whittaker.
You didn't.
Guess I got lucky.
Remember the burned farmer who came in last year? Propane tank exploded. He died in the ICU. Yeah, that was sad. Well, this guy has been playing house with his widow and their baby.
Oh, that's messy.
No, it's not.
You ever see a milking machine?
Oh, can we not talk about this, please?
We get tips.
So there are some major ethical red flags. If one of my junior residents was staying connected with one of his deceased patients' wife and family and hanging out with them and going to spend time with them on their farm and home, that would ring a lot of alarm bells in my head, and to the point where I might actually speak with the program director and to make sure that there's nothing else that sketchy going on, because I feel like you do need to draw a line somewhere, and that seems like it's either getting very close to the line or actually crossing the line.
Hi, the doctor guy told me to put this mineral oil in my eye for 20 minutes. That was...
Listen for your name to be called. Thanks. Next.
So this is realistic. Oftentimes we'll start some kind of therapy and push people back into the waiting room so that we can bring more patients into an assessment or treatment area, and kind of just cycle people in and out that way. It's not ideal, but it is the way that modern emergency medicine is heading, just given that we're inundated with patients.
You can wait 1 to 2 weeks for the super glue to break down on its own.
I'm hosting a 4th of July party tonight. You want me to show up like this?
The other option is I trim your eyelashes halfway down.
Yeah.
That'll lower the strength of the glue holding them together.
Let's do that.
Lie back, please.
I've done that before.
Well, I don't know a Dr. J.
She's one of the best doctors in Pittsburgh.
Oh, Dr. J.
Dr. J, finally.
It is so nice to meet you, Dr. J.
So what is Willow's health issue?
My eye, it's...
I'm laughing because this sometimes happens to me when patients come to the ER and say that they follow me on Instagram or TikTok or on YouTube. It is a bit of an odd situation that I'm still trying to get used to, but yeah, it's kind of funny. This hits close to home for me.
You did it.
Dr. J to the rescue. The medical influencer.
Oh my God.
No swab came back negative for COVID, influenza, and RSV, but a lot of other viruses can cause a cough.
Pulse ox is at 91.
Your oxygen level is down since we checked you an hour ago, and your temp is up to 102.4.
Okay, so there are a few things that are a little bit unrealistic about this scenario right here. So first of all, the lady is coming in with fever, cough, and low oxygen saturations. And even if the viral swabs came back negative, there are many other pathogens that can still be spread through the patient's breathing or coughing. For example, tuberculosis is spread by Mycobacterium tuberculosis, which are bacteria that go into very, very tiny airborne particles whenever you cough, and it can infect the entire room. So even if those viral swabs came back negative, I would still encourage the patient to continue wearing a mask. The second thing is, if a healthcare worker is seeing someone that's coming in with a cough, we would be wearing a mask ourselves to protect ourselves. And I guess, sorry, there's 3 things that are a little bit unrealistic. The last thing is, before we even do viral swabs, most people would actually send a patient for a chest x-ray to rule out things like a lobar pneumonia. It's one of the easiest screening tests for someone that's coming in with a cough.
If you're wondering. Hi, Miss Ronson.
How is everyone going into this room with a coughing febrile patient without a mask? That is just wild to me.
Okay, what'd you hear?
Maybe some crackles at the right base.
So crackles at the right base often points towards what we call a consolidation or a collection of pus inside the lungs. That would point towards like a pneumonia or some kind of chest infection.
Okay, well, we're gonna need a chest x-ray to check your lungs. Weird infiltrate. Have you seen it yet?
I've been trying to catch up on my charting.
Right here.
Yep. Stringy right lower lobe.
Yeah, it looks like aspiration pneumonia. Or an eating disorder.
Think she's bulimic?
Oh.
I mean, she's fixated on working out. Check the enamel behind her front incisors.
So what she's saying is if this person has an eating disorder that she's hiding and she's has purging type behaviors where she's forcing herself to vomit, typically what we see that the enamel, the hardest part of your tooth, can get worn down because of all the stomach acid hitting it. The other telltale sign that we see are the two fingers that are used to actually induce vomiting. The nails are kind of eroded and there's kind of like tooth marks high up on near their knuckles. Those are some of the signs that we look for clinically.
Do you ever drink a lot of alcohol? Maybe so much that you pass out?
No, I'm not a big drinker.
Have you had the stomach flu recently? Food poisoning?
No and no.
Do you mind if we take a look inside your mouth?
So what I would be teaching these residents to do is just ask the question. I think if you are treating the person as if they're like lying to you or withholding the truth and like you're trying to uncover the truth by finding these physical exam findings, it creates an us versus you dynamic where the patient is less likely to trust you or feel involved in their care. I would typically approach this in a very open conversation.
What?
The enamel on the back of your teeth is worn away.
Can you just give me some medicine?
Yeah, so if you do approach it like that, it forces the patient into a corner and makes them more defensive. So I think that this patient interaction could have definitely been handled better.
I have been making myself vomit. We eat when we're celebrating, we eat when we're mourning, we just eat. But then I got to college and it was all about how you looked.
Yeah.
That's a lot of pressure.
I'm seeing so many young people that have eating disorders, not only young women, but young men as well. I think social media and I guess just society puts so much emphasis on how people look. And this is causing people to spiral out of control and sometimes have life-threatening eating disorders where they need to be admitted to hospital and have feeding tubes, sometimes even a TPN or total parenteral nutrition where we're giving nutrition through the IVs because the eating disorder is so severe. It's a major, major problem that I'm seeing in the ER these days.
We can set you up with our eating disorder program upstairs.
It's here in the hospital.
It's an outpatient program. You'd meet with a therapist for individual and group therapy once or twice a week.
So what I would be doing at this point is I would actually be getting her body mass index to see how severe the eating disorder is. I would also take a full history to see how much weight she's lost. In her blood work, I would make sure that we're doing extended electrolytes with calcium, magnesium, phosphate levels to make sure that she's not at risk of something called refeeding syndrome, where once she starts eating again, it can cause a lot of life-threatening electrolyte shifts. Because this is what would steer us in the direction towards an admission to hospital, sometimes even an involuntary admission where we put a feeding tube into their stomach to give them nutrition versus sending them home and allowing them to come back to hospital as an outpatient for these eating disorder programs.
Would you be open to meeting with a therapist?
I guess.
Do you have any preference for type of therapist, male, female?
If there's a black woman, I'd like that.
This is all really great questions that Mel is asking. And I love that they included this in the TV show, that this African-American patient is requesting a black doctor or a black therapist. It's proven through research that there's incredible amount of historical systemic racism against people of color, particularly black people, and that when black patients were matched with black doctors, they were much more likely to get care for high blood pressure, diabetes, take medications, and have better outcomes down the long run. So it's really important to ask patients what their preferences are for therapists, because you just don't know what their trust level is with like Caucasian doctors or other doctors of different ethnicities.
Yeah, we can arrange that.
Thank you.
You know, I love that the Pit includes so many human stories like this. It's just, a lot of medical TV shows just focus on the gore and the rush of emergency medicine, but this is really one of the core aspects of being an emergency room doctor. Being able to have these deep heart-to-heart talks and being able to meet them where they are and to provide them with resources that will get them into a better place. So I think that they did a really good job, and I love these storylines in the Pit.
Okay.
Oh, let's see.
3 cc syringe, 20 gauge needle, entering at the juiciest part,
Yeah.
aiming for the apex.
Draining abscesses is one of my favorite things to do on the job. It's just
Done that for
so
culture.
satisfying.
No, pen VK for a few days. Folks
Yeah.
in the mouth are old school.
Just like me.
How serious? Can he go home?
We still have to clear the ketones from his bloodstream. He'll need to be on an insulin drip for a while until things get back to normal.
In bad diabetic ketoacidosis, especially someone that was like came in with altered mental status and was slumped over like he did a couple of episodes ago, there is no way that this guy would be discharged home. He would actually be admitted to the ICU really, so that they could be doing hourly glucose checks and to make sure that his potassium is not shifting in a way where he's getting into danger zones.
We don't have health insurance, so I don't think that we can afford this.
This, I think, is the saddest thing about American healthcare. You know, having to, you know, consider withholding vital tests or vital procedures or therapies because patients either don't have health insurance or they don't have the ability to pay out of pocket. That would just tear me apart as a healthcare provider.
But the ER visit alone will likely be in the thousands.
Bro.
We will
Bruh.
figure something out. Okay?
Just what we thought. It's a fracture of your coccyx.
The coccyx is the tailbone.
Your tailbone.
Oh.
I see these pieces here should be lined up with that part here.
Do I need surgery?
No, these heal pretty well. But it'll take about 6 weeks.
No. Yeah, bones take about 6 to 8 weeks to heal. And during that time, it's going to be incredibly painful for him to sit or poo.
6 weeks?
Mm-hmm.
I have dinner dates every weekend. A nightcap at my place usually follows, and then breakfast in bed.
Okay. Well, in that case, you might need to take a little break.
You know, it's funny that they're adding this aspect of the story for this elderly gentleman. One of the most rapid populations that syphilis is spreading is the elderly population because they're having so much unprotected sex because they think, oh, I can't get pregnant. We don't need to use condoms or any form of protection. And we're seeing a lot of elderly people coming in with STIs now.
Well, there is a procedure to push the fragments back in place. It could help it heal faster. You know, I was gonna go check out a few of the art galleries in Lawrenceville tonight.
Have you been to that one on 40th and Butler?
I don't know. That is crossing the line, man.
By maybe around 9.
Okay.
That's a no-no. That's a no-no. Oh.
Here we go. Try to relax. Deep breath with your
Wow.
mouth
Wow.
open.
I can't believe they actually got the actor to let her stick the finger up. I can't believe this. I can't believe they actually did that. That's crazy.
That's our first
That's commitment.
encounter.
Okay.
I wonder how much they paid this
Got it.
actor.
Now on 3. Okay. 1,
Oh.
Motherfucker! Oh, you son of...
I know. Sorry, it keeps you from tensing up.
Can I give you a hug?
Maybe later. Okay?
It's gross that she touched the curtains with the gloves still on after she went straight up his rectum. Oh, gross.
And who do we have here? Vince Cole, 23, fell through the skylight of a florist shop, then beat down to a bunch of ferns, complained of headache, asking repetitive questions, and only response to pain.
Multiple acts from the glass, VP 118 over 72, pulse 98, sats 99 on 5 liters, no meds, no allergies.
Hey, Vince, how'd you fall through a skylight? Vince!
So this guy has what we call a polyblunt trauma. He fell from a significant height. There's significant head trauma. Has altered mental status. I don't know they didn't mention what his GCS was, but I'm guessing that his GCS is somewhere in the range of 8 to 10 right now, given that they're saying that he's only responding to pain. He has abrasions all over his body, but his vital signs sound somewhat stable. So this is also another patient that would be a very high priority triage score, essentially taken in immediately to the trauma bay where we would do an EFAST, start resuscitating him, and do investigations with a pan scan where we scan him straight from the head all the way down to the pelvis.
Were you with him?
Yeah, we were parkouring and he overshot a Congo.
But like jumping off of buildings, people still do that?
It's almost an Olympic sport.
Yeah, okay, parkour injuries are just absolutely brutal. We see a lot of bad wrists, bad ankles, and these days, because people are posting a lot of their videos on Instagram and social media, I feel like the bar keeps pushed higher and higher for how extreme things people are doing. And you start to see people that are jumping from, off of buildings, essentially, to slide down and land on the ground and roll their way out of it. But the injuries that we're starting to see because of parkour are pretty insane.
EFAST is negative. Music to my ears.
So there's no signs of blunt internal injuries, like a ruptured spleen, liver laceration, ruptured bowels, or anything like that, at least for now. But typically we repeat the EFAST multiple times during a blunt polytrauma like this. And I guess the other thing that's a little bit odd is that they're allowing this person to continue filming with her GoPro. We would not allow that in like a trauma resuscitation.
Somebody shooting a documentary here?
Whoa, you can't film in here. We've got patient privacy laws. What happened to your hand?
Cut it.
A gag. We need to intubate before CT.
Yeah.
Can I do it?
If Dr. McKay wants to teach.
Sure.
Okay. I need suction, 802, etomidate, and sucks. End tidal CO2.
So etomidate and sux are two medications. Etomidate is a sedating medication. Succinylcholine is a paralytic medication that is fast on, fast off. Typically comes on within about 30 to 45 seconds and resolves within 15 minutes. Succinylcholine is not very commonly used in modern day practice, but the few indications that we do use succinylcholine are for really bad brain injuries like this. And the reason that we use succinylcholine is because we want the paralytic to wear off as quickly as possible so that we can actually continue doing neurologic checks by, squeezing their nail beds to see if they're withdrawing, to see if there's any true neurologic change. We typically would not use rocuronium, which is the other main alternative, which typically lasts in your system for 60 minutes because we would just not be able to check your neurologic status during the entire 60 minutes.
Student debt. Superficial ones get a steri strip, full thickness triderma bond. How can you tell they need a suture? Joy.
If the edges are under significant tension.
So right now what they're talking about are different ways to close a wound. They're saying that the most superficial ones, or the ones that are closest to the surface, are closed with a sticker called a steri strip. Deeper ones or full thickness ones are closed with dermabond glue. And ones that are under tension are closed with a suture or a stitch.
Chest and abdomen CT scans also showed no major internal injuries.
This guy's super lucky.
What's that?
Oh.
Huh. Over. Good. Oh, shit.
Okay, left flank area.
Careful, everybody. There might be glass.
2 centimeter simple laceration.
No, but when we moved him around for CT, it might have rubbed off a clot. Slow venous oozing.
Might need a figure of 8.
Figure of 8 stitch is a specific technique that we use to ligate or kind of close off small little vessels. This is a very common surgical technique that we use for big open wounds that are bleeding.
Is it a loose fragment? Yeah, I can wiggle it around. Here, I'll pull it out.
No, don't.
Ooh.
Shit.
So he's pulling out a large shard of glass without knowing the depth. Again, I think if the CT scan of the chest, abdomen, and pelvis was already done, they would have already captured that. But I think what they're trying to allude to in this conversation is that maybe they placed him onto the shard of glass, which punctured him after the CT scan, which I think is a little bit unrealistic because typically we take all of their clothes off and clear the beds and make sure that there's no other objects that are kind of left behind so that this doesn't happen.
It's bigger than I thought it would be.
Pressure on this from both sides, hard and deep, please.
I can push it back in.
Don't push it back in. Don't do it.
Damn it.
Or should I keep pulling it out?
Just keep it there.
Not. The glass was tampered on a vessel.
Not anymore. BP's down. Page surgery?
What the fuck? He was stable.
Slight change in status.
Okay, get the clamp ready.
Who's the genius who pulled that out?
So what they're doing right now is they're stabilizing the shard of glass with rolls of gauze on both sides. And what they would do is usually take this patient to the operating room. And once he's in the operating room under sterile conditions, they would actually open up the wound more to try to find the bleeder and kind of tie a knot around it. The other way that they would be able to address this is using interventional radiology, like x-ray machines with IV contrast dye that's pushed through to see if they can see where it's bleeding from. And then they would do what we call arterial embolization, where they use coils or different methods to actually clot off that vessel.
There's a radiopaque foreign body in the left paralumbar musculature.
So this does happen where a radiology resident reads a scan, reads it totally normal, and we make decisions based off those reports. And if something was missed, it's on the attending radiologist to call the ER and let us know that something was missed so that we can actually change our management plan. The one thing that I will mention that's quite unrealistic is if there was that big of a shard of glass on inside that person's body and he went through a CT scanner, there's no way that even a junior radiology resident would miss that. Big shards of glass like that would be very radio opaque. It would show up as a bright, like a white object on the CT scan and in a sea of black. So it would stick out like a sore thumb. Like there's no way that anyone would miss that.
Langdon.
I wasn't expecting to see you back so soon. Meds upset your stomach?
No. The pain got worse, and you said to come back if the redness spread outside the Sharpie line.
Let's take a look.
So common things being common, this is what we would call a cellulitis or a skin and soft tissue infection. But given that it spread so rapidly outside of that line within a course of like 1 or 2 hours, the thing that we would think about is necrotizing fasciitis, which is flushing disease.
Not if we can get a handle on it. MRSA, or maybe worse.
MRSA, what he said is MRSA, or methicillin resistant Staphylococcus aureus, which is in a type of bacteria that is resistant to a lot of typical oral antibiotics. And what Langdon is referring to is necrotizing fasciitis, what I was referring to a little bit earlier. All right, so that's it for season 2, episode 4. Another great episode, but I did think that there were some inaccuracies. For example, the first one, which is a glaring and obvious inaccuracy, is a radiology resident missing a large shard of glass that's kind of punctured through the flank. There is no junior resident that would ever miss a large foreign body like that on a CT scan. So I just don't think that that was realistic. The second one was delaying the posterior ECG because the nurse wanted to go assess a different patient that's septic. You know, if someone has crushing chest pain and is that diaphoretic or sweaty, and even a first-year resident asks for posterior leads because they're concerned, typically we would perform the posterior ECG right away. But I think one of the general themes of this episode is the screenwriters seem to be planting a lot of seeds for some of the ethical issues among a lot of the coworkers. For example, one of the first things is the betting among coworkers. I think in general that's quite frowned upon and a big no-no. The second one is they mentioned that Whitaker is hanging out with the family of one of his deceased patients. That is clearly far over the line of moral and ethical conduct. McKay also agreeing to go on a date with one of her patients. That's another big no-no that could, get you in big trouble with the college. And the last one is Javadi having a large social media following where she's portraying herself to be a doctor, Dr. J. I'm sure that a lot of these storylines will be fleshed out in the further episodes, and I'm really curious to see where they take it. But if you thought that this episode or this reaction video was insightful, entertaining, educational, please give it a like. Support this channel by subscribing and turn on the notifications, and I'll see you in the next one.